Welcome to Pediatric Dentistry. My name is Dr. Kunal Bhatia, and I'll be covering this lecture under the following headings: mainly the patient, the pediatric patient, what to expect, the various changing trends we are seeing in dentistry and pediatric dentistry, the various treatment considerations you need to keep in mind, uh, a slide on preventive dentistry, a few tips and tricks which you can implement in your private practice, what is expected of you as a student, as a clinician, as a general dentist, or as a pediatric dentist. You need to meet certain expectations, you need to have a certain checklist in mind. Only then can you expect to have some sort of success as a dentist in general. And finally, a bonus content on the aspiring postgraduates and first year fresh postgraduates on how to come up with a thesis topic or any research topic for that matter. Now, when you look at a pediatric patient, you need to keep in mind that this patient is not constant, and the clinical situation which you will be seeing now will not be the same when you meet the same patient after, say, 1 to 2 years. Children are dynamic individuals. They keep growing and developing, right? The jaws will look different. The height and weight and the behavior of the patient will keep changing. So you need to have that in mind, that whatever you are seeing now is not constant. It's undergoing a drastic change over time, and it is your moral responsibility to guide that process in such a way that the development happens normally. Okay, and each stage will have its own various characteristics, and by that I mean the patient's intelligence or cognition, the various craniofacial development which is happening, the changes which are seen in the craniofacial structures of the patient's jaws, and then the dentition. Everything keeps changing. At the same time, you're going to see the patient reacting in a different way to different risk factors. I focus predominantly on caries risk profile. If I say that patient A has a higher caries risk than the patient B, if I offer both of them one chocolate, doesn't matter if they're both of the same age, same gender, they will react differently to that. One of them may develop caries much more rapidly than the other, and that's simply because they each have their own unique caries risk profile. Now, this slide is taken from my next lecture, which is mainly targeted on the dynamics of change, which you see as per each age group. If you take an example of the preschooler, when you look at the cognition, the craniofacial development, and the jaw changes, the psychological changes, and the dental changes, each of them have certain unique characteristics. Preschooler will start to have conversations in small sentences, right? You can have a conversation with a preschooler. It's not like you can't reach to him, but you have to talk in a very simple fashion, right? When you look at John Piaget's cognitive theory, it says that such children are considered under the pre-operational stage. They are very imaginative, they fantasize, right? They play like that, they do daydreaming, they are able to form mental imagery, and you can use that to train them or to make them understand complex concepts, right? They also have centration. They cannot multitask. They can focus only on one thing at a time, and for that you need to show them the entire treatment process one step at a time, so that they can focus, so that they can understand you. You both can be at the same page, and at the same time they generalize everything. So every flying object becomes bird, but at the same time every loud noise is scary for them, right? They will not differentiate between the noise coming from the aerator or from the suction. If it's a loud noise, children will be scared. So you need to keep certain things in mind, certain behavior hacks, and your formula of handling a pediatric patient will be unique to you. The way you want to do behavior management is completely up to you, and that for you to design that, you need to keep these principles in mind. At the same time, the preschooler, if you look at the physical changes, right, the body is growing steadily, okay? The heart rate is decreasing. This becomes especially important when you are positioning a patient, If you try to position a toddler in an extremely supine fashion, if you make them completely lie down, for adults it is encouraged that it improves blood flow towards the head, so chances of syncope reduces. But if you take a toddler and make that patient completely supine, because of the low heart rate and respiratory rate, the diaphragm gets stressed and the patient's respiratory rate goes down even further, right? So something to keep in mind there. At the same time, their bones are getting more and more calcified. If you're going to use a local anesthetic in a patient of this age, keep in mind that the diffusion of local anesthesia will be much more rapid because of low calcification of the bone, and gradually the calcification will increase, so the diffusion of local anesthetic will also decrease. There will also be growth in the face and the lowering of the palatal vault. There will also be dentoalveolar growth due to erupting teeth. But for the most part, the undergraduate is going to focus predominantly here, right? The dental changes. You're going to try to identify which teeth are present in the patient's mouth. Since this age group ends at 5 years of age, once the permanent teeth start erupting at 6 years of age, your focus solely goes on differentiating between primary and permanent teeth. You're going to observe the morphology of the primary crowns and roots, right? And at the same time start correlating the patient's dental age with the patient's chronological age. Now, while I do understand the constant focus on the dental changes, for you to be a more comprehensive dentist, you cannot ignore these, right? The way the patient is behaving is very important for you to have a rapport with the patient, and for you to start hacking those characteristics and form a bond with your patient. At the same time, you cannot ignore craniofacial changes. If at all you're able to catch a habit, you will be able to observe certain craniofacial changes which are happening because of that habit, because of any parafunction. And if you have noticed it, it is your moral responsibility to intercept that habit, to correct any parafunction whatsoever, and only then will the patient's growth be guided appropriately. So for such a dynamic individual, right, who is continuously developing, our field becomes multidisciplinary. We are not doing just restorative dentistry, not just caries excavation or extraction of primary teeth. There are far more specialties which need to be explored, and all of them happen at once. And that's the biggest challenge, biggest advantage of pediatric dentistry, because you are dealing with everything. You do not lose touch with any other field of dentistry if ever you decide to specialize, right? You need to focus on cariology, you need to focus on the patient's immunity, preventive dentistry, the patient's gingival status. You're going to do endodontic procedures, and you're going to do oral surgery as well, cyst enucleations, extractions, frenectomy, frenotomy, the list goes on. And that also needs to be kept in mind whenever you are approaching this field in general. You're going to have your fingers dipped in all pots. Over time, the trends of managing a pediatric patient or managing a patient in general when it comes to dentistry, the trend is now gradually changing, right? Earlier there was a time if the tooth was infected, you would extract that tooth. Now we know that there are more conservative approaches. You can save the teeth, you can intercept caries, and you can do great restorative procedures, and you can do root canals in both primary and permanent teeth. And more priority is being given to saving the teeth rather than just extracting the teeth. Again, you become an advocate of this process. If the parents ask you, these are just milk teeth, they are going to fall off sooner or later, what compels you to tell them that no, we have to save the teeth for as long as possible? It becomes your job to actually educate them. If you yourself don't know why we have to preserve the primary teeth for as long as possible, primary teeth are required not just for space maintenance but for speech development. There are certain words, when you look at phonetics, there are certain words which require the upper front teeth to be there so that the tongue may come in contact with them. You say words like tooth, you say F, you say S. The teeth are in action. You cannot pronounce these words unless your teeth are there. And for adults, it's a different story. But for a pediatric patient who's just learning how to speak, right, phonetics become important. They need to learn certain words correctly while their speech is being developed. And that happens in the early ages, right, before the ages of 5. After ages 6 to 7, yes, primary teeth will start exfoliating on their own. But till that age, you need to preserve them for as long as possible till they exfoliate naturally. And the journey from the undergraduate to an intern to a clinician, you're going to explore all of them. As an undergraduate, you're going to do all these processes at least till the restorative techniques. And yes, if you do get enough exposure, you're going to learn pulp therapy, invasive pulp therapy, and at the same time space management, right? The priority has to be given to the arch integrity. And your training also includes a fair deal of preventive procedures. Another thing which needs to be kept in mind is regeneration endodontics, bringing a dead tooth back to life. It is possible, but it is possible only in kids. It is possible only in immature permanent teeth, right? Regeneration endodontics is the next frontier when it comes to doing endodontics for children. And you're going to essentially induce stem cells in the apical papilla region, and you're going to induce complete root development. If the tooth survives, well and good. Otherwise, you can consider doing a conventional RCT, but you have caused complete root formation. If you see a half root formed, do not go for apexification, and otherwise you'll end up with just a compromised crown root ratio because the roots will be so small. You have to consider regeneration endodontics, and that is again something which we learn in pediatric dentistry. Regardless of everything, the goal remains the same. You have to provide a child an ideal oral structure. And by that, I mean not just in appearance, but also in function. You have to correct parafunction. You have to ensure the position of the tongue and all the musculature is correct. The muscles are working normally. There is no abnormal positioning of the tongue. The child is not lisping. The child does not have any tongue tie. The child is not having bruxism. And the child is not having any other habits. You have to correct that. You have to restore the function, and only then are you going to focus on the aesthetics. Your training from second year to third year to final year focuses a lot on treating the pathology. You're going to do caries management. You're going to look at the periodontium, and you can treat them as well as you want, but you cannot leave the patient without correcting the function. Once you have cleared the child of any pathologies, once you have restored the function, only then focus on the aesthetics of it all. And that allows you to be in a different mindset. The mindset will be that you have to restore the original healthy status of the patient's oral cavity. You have to acquire homeostasis for the individual, and you have to ensure that the oral microflora which exists in the patient's mouth is again restored to normal healthy levels. That is called eubiosis, right? You do not want dysbiosis. You do not want more karyogenic bacteria. You want a normal healthy oral microflora. Once oral pathologies are dealt with, you're going to correct the function. You're going to intercept all habits. You're going to train the patient into opening and closing the mouth properly. You're going to ensure that they're not having any thumb sucking habit. You're going to ensure their airway is not clogged. You have to work with ENTs. You have to work with physiotherapists and ensure that the patient's bodily functions are occurring normally. Once you do that, you can put some focus on the aesthetics. For a student, just these two is adequate. No one is expecting more from you. Granted, if you are able to achieve aesthetics of it, you will gather accolades, but for now, focus on only these two. Over time, when your work gets more and more refined, you're going to focus on aesthetics. And finally, once everything is said and done, you have to ensure that your treatment results are stable, right? This is where preventive dentistry comes in. You cannot just straight away jump into preventive dentistry without dealing with pathologies, without dealing with parafunction, without dealing with even aesthetics for that matter, right? You need to first meet those 3 criteria, and then you have to stabilize your treatment. And if you do all of it, you're going to have the ideal treatment. This is something we all want. This is something which is glamorized even on social media, right? You're going to see ideal teeth structures, and this is something which everyone aims for. I can tell you right now, it is very, very difficult, next to impossible, for you to achieve ideal results early in your career. Right? Do not expect it to happen. Even if you correct the patient's dysbiosis and the patient's parafunction, you are set. The patient will still be happy. Okay? So for a learner, focus on these two. Over time, when you become a seasoned practitioner, your results will start becoming more and more aesthetic, and with years and years of practice, you'll be able to stabilize your treatment completely, right? You will end up becoming a stalwart of your field, and that's the career trajectory we are all hoping for. So what barriers lie in front of you when we say you're not going to achieve ideal results, right? Patient's behavior, parafunction, and various considerations we will keep in mind. Certain things will be there right there in front of you, and you need to overcome the said barriers. The journey from getting a patient from the waiting area to making the patient sit on the chair and then finally start to ask them the questions of your case history, that journey should not happen very rapidly in a very hasty fashion. You need to have certain questions set in your head. You need to have a mental checklist which you need to ensure that you're going through. Okay, you cannot straight away jump into asking the patient to open the mouth and start doing oral examination, right? You need to ask yourself, did you make a mental note on the patient's behavior? Just by looking at a patient, if the patient is showing signs of apprehension, you need to differentiate whether that is anxiety or whether that is actual phobia, right? You need to make that distinction, and you can do it in just a small hi and hello that you say to a patient when they're still in the waiting area. Okay, you need to gauge that patient's behavior. Okay, you need to ask yourself if you observed any habits or parafunction. The trained postgraduate or a practitioner or a specialist can tell just by looking at a patient that this patient has some parafunction. The patient is a mouth breather, the patient has lip biting, and maybe a potential tongue thruster as well. All of these have their manifestations written right on the patient's face. If you are trained correctly, you can observe these changes even before the patient says anything to you. Would you consider radiographic examination? Once you do ask the patient to open the mouth, if you do see a pathology, you need to ask yourself whether the patient requires any radiographic evaluation. If you do see carious lesions, you need to ask yourself if you will follow conventional restorative dentistry. I want you to think of your second year undergraduation phantom head training. The principles of cavity preparation, G.B. Black's principles of cavity preparation, are those still applicable today? Those principles were designed for dental amalgam, right? Now we have more adhesive materials, more conservative materials which do not require mechanical retention. You're not using pins, right? Even now we are trying to eliminate post and course because they induce so much stress inside the patient's root canal, right? Gradually we are moving away from mechanical retention. We are moving towards chemical adhesion. So when you have such materials at your disposal, will you still follow conventional dentistry? Will you still prepare an ideal class 1 preparation or a class 2 preparation, that butterfly shape, that dovetails, all that? No. For the most part, no. You're going to be ultra conservative, as conservative as possible. We'll go through the process on how to achieve that. And would you consider a root canal treatment for a child the same way as for adults? The obvious answer is no. Right? The morphology of primary teeth is very different from that of a permanent tooth. Right? We are not doing shaping and cleaning like how we do for permanent teeth. This is why pulpectomy is different from a conventional root canal treatment. Similarly, for permanent teeth in a child, if the apices are open, if the apex is not closed, you can't do conventional root canal treatment. You need to consider either apexogenesis or apexification or regeneration endodontics. Whether you need to consider whether you need to have any pre-surgical considerations. If the patient has been sent to your operatory with the instruction that this patient requires some sort of surgery, that decision has already been made, or whether you do your own examination and come to a decision that the patient requires some surgical intervention, what considerations you will keep in mind before you start. We'll go through all of them. This is where majority of the people are stuck. This is literally the first barrier you're going to encounter, the first of many, right? So you cannot afford to get limited to just this. I got a lot of requests in the feedback form of conducting lectures on behavior management. I can tell you right now, there is no textbook which is going to teach you behavior management. No textbook exists which is going to give you a sure shot formula for making every uncooperative patient cooperative, right? And this is where most of the clinicians are going to get demotivated. The way we are trained, we read a book, we are explained the topic by a lecturer, and we try to implement it clinically, and then we succeed or fail. That becomes a little different when it comes to behavior management. Behavior management is an extension of your own personality. The way you or your colleague will tackle a pediatric patient is different. Okay, we have certain guidelines. Sure, the textbooks will teach you certain guidelines. They're going to help you differentiate between anxiety and fear. They're going to help you understand the psychology of a patient, but every patient is different, and you cannot just hope to apply the same principles for each and every patient. You're going to do your own thing, like it or not, right? You have to develop your own formula. A guide which I can tell you right now, do not try to coddle a patient. You do not do kuchi 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 to a patient just like that. You cannot do that to a 12-year-old or a 14-year-old. The methods of trying to make a child more relaxed, they're different, and they're different for every age group. Even if you don't like children, even if you don't have any love and sympathy for children, and you're doing pediatric dentistry because you're simply forced to do it, it is still possible to be respectful of a patient, and it is still possible to make a patient calm. If you are calm, if you are able to maintain a composure, there's a very good chance your patient will be calm as well. The more you fluster, the more you throw your hands around towards the instruments, adjust the light and chair, the child can sense it. Children are very good at sensing body language. And for you to develop that confidence, you need to have some nerves of steel, right? You have to train yourself into developing a mindset which is calm. Slowly, you have to explain things to a patient. You have to show them things in a non-threatening fashion. You do not have to be their friend, but you do not have to be a scary authority figure either, right? Just simply talk to them like decent human beings, and 90% of the time that works. Okay, the factors which complicate this process is, one of them is parental influence, right? Legally, we are bound to keep a parent or a guardian in front of a patient, right? Someone has to observe what we are doing for protecting the child's rights, and that is understandable. But if that guardian, if that parent is extremely apprehensive, their anxiety is going to get imprinted on the child as well. There's a very, very high correlation of parental anxiety with the child's own anxiety. Okay, so one hack which you can keep in mind is to first learn how to keep a parent calm. If you can talk to them, they are not children, they are adults, they can reason with you. If you talk to them first, if you ensure that they are calm, the job becomes much easy. If your parent, if the patient's parent is continuously threatening the child that behave, or the doctor is going to give you an injection, you need to discourage such behaviors, right? You need to tell them, please do not threaten your child with injection. If your child actually does require an injection, he or she will think that they are being punished. Okay, parents have a role in protecting a child. They have a role in ensuring that you do not violate the child's right, but they should be minimally involved when it comes to you talking to the patient directly. For you to establish a rapport with your pediatric patient, the parental influence should be absolutely minimal. Same goes for your support staff. If your sisters in your department are continuously trying to intervene and they are trying to talk to your patient, the rapport between you and your patient is going to break. So respectfully tell your sisters, let me talk. right? Such things will help you in the long term. Then and only then, if you realize that you are just not able to establish a rapport with the patient, no matter what, you have done tell-show-do, you have done communication, you have done everything in your power, only then you consider pharmacological management. Okay, just because a child is showing signs of apprehension, just because a child is getting slightly anxious in your chair, do not get up and go to your professor saying the child is uncooperative. No, you have not tried enough. Okay, keep in mind, most of the things are learned well if you learn them on your own. Okay, we can hold your hands to a certain degree, but most of the job you have to learn on your own. Okay, again, one more thing which I would like you to understand: there is a difference between a non-cooperative patient and a pre-cooperative patient. Okay, a child below 4 years of age, or let's say a child below 6 years of age, is extremely prone to apprehension. Okay, if the child is simply not able to understand your words, your actions, let's look at a toddler, right? A child 3 to 5 years of age, if you, let's say the child is 3 years of age and he or she is just not able to understand your words simply because they don't know those words, or you don't know a way to explain something to them, right? Then that child can be considered pre-cooperative. Okay, the child is simply not able to cooperate because he or she lacks the ability to understand what is being told to him or her. Okay, that patient is not non-cooperative, that patient is pre-cooperative, a child 3 to 4 years of age or younger. Okay, if you do see a slightly elder child who is able to understand basic vernaculum, be it in any language, and still the child refuses to understand what you're trying to tell them, then yes, you have to call that patient non-cooperative. I hope you appreciate that distinction. And whenever you see an extremely young child in front of you, first ask yourself whether the child is pre-cooperative or non-cooperative. Now moving on to habit assessment. Again, this is something which I like to see extra-orally. I confirm my findings intra-orally, but I personally like observing habits extra-orally. The journey from the waiting room to the chair. If you can learn how to pick those signs, you can catch certain things. Okay, because these habits have an effect on the patient's developing jaws. Any patient who has undergone orthodontic treatment, any of you who have undergone orthodontic treatment, myself included, right? Every ortho patient has had some sort of parafunction or the other, right? Be it hyperactivity of any muscles, be it an improper tongue posture, there would have been some evidence of any parafunction in the patient's lifetime. Maybe that parafunction got resolved as the patient grew older, but some degree of parafunction almost always exists. Only in cases where you see a complete genetic discrepancy of the tooth size and jaw size will you have some orthodontic problems. Most of the time, I would say, if I were to give a number to it, 90% of the time there is some parafunction. Okay, which is why retention is such an important factor in orthodontics, right? You can correct the teeth position, but if you don't target the parafunction, retention is more and more challenging, right? Habits have an effect on the developing jaws, right? If your patient's mentalis muscle is hyperactive, right, it is exerting around 300 grams of force on the developing mandible. The mandible will be retroclined. The mandible will not reach its full growth potential. If the patient is a mouth breather, you're going to encounter a long face. You're going to see tired, baggy eyes. You're going to see hyperactivity of the masseter as well. Okay, and because the child has some sort of nasal obstruction, if at all this is an anatomical obstructive mouth breathing, the patient will slowly start putting the head forward. You will see slouching, hunching, because the patient is involuntarily trying to open up his or her airway. Okay, if you see patients who are slouching forwards while walking and while standing, suspect some sort of airway obstruction. All it takes is one consultation to an ENT. That's it. Send the patient to an ENT. Ask them, please evaluate the patient's airway. most of the time you're going to see some anatomical obstruction. If you don't see any anatomical obstruction, then it's a habit, and that habit requires correction. In a pediatric patient, radiological considerations are slightly different. Radiation protection becomes more and more important. Extremely young individuals and extremely old individuals are more susceptible to ionizing radiation damage. Okay, girls are more susceptible to radiation damage than boys. Okay, your thyroid gland is more susceptible to absorbing radiation than other tissues of the body. Now, your thyroid gland contains NADPH enzyme, and that leads to a lot of reactive oxygen species. Free radicals are being released, and that increases the risk of thyroid cancer or thyroid disorders when a young patient, especially females, are exposed to ionizing radiation at a young age. So for every patient, you need to use a lead apron. You can consider using a thyroid collar along with the lead apron. Most of the lead aprons come with a thyroid collar inbuilt by itself. So start using these. Every radiological operatory will have at least 2 lead aprons, one for you, one for your patient. Insist on using them. Okay, if you come from some unfortunate institution which does not have radiation protection, at least buy your own dosimeter and still insist to your department head to please buy 1 lead apron at least for the patients. Okay, when you're running your own operatory, do not work without lead aprons. Size of intraoral X-ray films is also important. You cannot use your conventional IOPA films for a pediatric patient. They're just too large for them. They will gag. So you need to use size 0 X-ray films. This is something which most of you know already. Children also have a tendency of biting on the X-ray films, regardless of whether they're kept in a film holder. So you need to talk to them, encourage them not to bite, and if they continue to do so, maybe consider extraoral radiography. And still, if you want to do intraoral radiography, go ahead, but do not use an RVG sensor. RVG sensors are digital sensors, but they're extremely expensive. If you're going to use a small RVG sensor which is flexible for a child, and if a child bites on it, you're going to lose a lot of money. Endodontic considerations. We know already that the pulp chamber and root canal morphology of primary teeth is vastly different from that of a permanent tooth. So your conventional principles of root canal therapy may not be applicable for a primary tooth. You can still follow principles of access cavity preparation. You can still do your working length determination in normal fashion, but the amount of tooth structure you're going to remove during biomechanical preparation will be very, very less. Okay, you're not going to get the ideal conical and cylindrical root canal forms in a primary tooth. They're simply not designed to be that way. You can use a lot of rotary endosystems and try to achieve that kind of a canal morphology. It's not going to happen. Okay, biomechanical preparation is just not sufficient for complete disinfection of a primary tooth root canal. You need to rely on chemical irrigants. Okay, chemomechanical preparation is more important than biomechanical preparation for primary teeth. At the same time, we know that primary teeth are going to resorb over time, so your root canal obturating material is also going to change. You need to use an obturating material which is going to go inside the root canals, and it is going to resorb at the same time or approximately the same time as that of your primary tooth. The pulp chamber in itself is highly cellular. Okay, the pulp in primary teeth has a higher capacity for repair. Your primary teeth will try to repair themselves at a much more rapid rate than the pulp of a permanent tooth, which is why you're going to encounter more pulp polyps in a primary tooth than a permanent tooth. Okay, in terms of endodontic classifications, this one, proliferative pulpitis is more common than ulcerative pulpitis. Ulcerative is just an exposed pulp. This is more common in a permanent tooth but not in a primary tooth. This high cellularity is also a barrier when it comes to pulp capping. If ever you decide to do a direct pulp capping on an exposed pulp in a primary tooth using calcium hydroxide, the tooth will die. Right, the tooth is going to undergo resorption, the primary pulp is highly cellular. All of them are going to differentiate into odontoclasts. They're going to eat away the tooth. Never put calcium hydroxide directly on a primary tooth pulp. Do not ever do it. Okay, it is extremely caustic, extremely irritating. If at all you have to do direct pulp capping, you have to use MTA or biodentine. Otherwise, go ahead with pulp removal. You can do pulpotomy, you can do pulpectomy, but do not do direct pulp capping with calcium hydroxide in a primary tooth. When we are looking at permanent teeth, we have to mainly focus on the root length. Okay, a small root, you cannot just simply put MTA and close the apex. You can't do that. That will compromise the crown root ratio. Over the long run, the tooth will become stable and will get compromised periodontally and will get dislodged and lost early than it was supposed to. So consider doing apexogenesis if the roots are smaller. If the pulp is completely necrotic and the canals and the apex is open and the roots are short, consider doing regeneration endodontics. This is again something which we'll cover later. It is beyond the scope of this lecture, but keep in mind that there is a procedure which exists which can bring a dead immature tooth back to life. Certain considerations you're going to keep in mind when you're doing restorative dentistry. You have disinfected the tooth completely, right? You have removed all the pathogens from the root canals. You have removed all the carious tissue. The tooth is completely free of any necrotic material. Now it is time to restore the tooth. If minimal tooth structure is lost, okay, you are not justified in over preparing the tooth further. Whatever is lost, you repair. Okay, if at all you have to remove any additional tooth structure, remove only the unsupported enamel. Unsupported enamel essentially is the type of enamel which is intact from the top but hollow or concave at the bottom. Okay, you need to ensure that whatever enamel is there at the top is well supported by an enamel layer at the bottom. Otherwise, that extra lip of enamel will fracture eventually. It will create rough areas onto the tooth structure. It will attract plaque and will lead to secondary caries. So remove only the unsupported enamel. Otherwise, don't remove any tooth structure at all. Disinfect the tooth completely and then restore. You have plenty of aesthetic materials available now. You can use composites, you can use glass ionomers, you can use compomers, you can use geomers. This one, Activa Bioactive Restorative, is the latest bioactive material. It is sort of like a resin modified GIC and sort of like a compomer. And basically it contains matrix which is rich in calcium and phosphate ions, and it serves the purpose of composites as well. So it's a very, it has dual advantages. You can consider using this. It is very, very expensive. So maybe not in the early stages of your career. In the meantime, consider using conventional resin modified glass ionomer cements, but only for primary teeth. I will never recommend using resin modified glass ionomers for permanent teeth. Okay, it is supposed to combine the best of both worlds, resin composites and GICs, but clinical testing has shown that it is inferior to both of them. So you can use them, but for a tooth which has a limited lifespan in general, which is all the primary teeth. Okay, it is great for kids, not so much for permanent teeth in adults. For any procedure that you are doing, you have to be minimally invasive. Okay, we have developed enough materials now for you to be minimally invasive. You do not have to be so invasive for every patient. Conserve the tooth structure as much as possible. We are slowly moving away from crowns as well, right? We are entering the age of biomimetic dentistry, using onlays and inlays more than crowns. So the focus is now on being minimally conservative. Okay, nothing replaces the original. You have to preserve the original tooth structure as much as possible. Certain things which you can keep in mind if any oral surgical procedure is being considered for the patient. Okay, this is where a lot of academicians, a lot of students show interest that they want to do oral surgery for patient. They want to learn oral surgery. I personally feel your job is to save the teeth more than focus on removing them. So even if you don't get a chance to learn exodontia to such a detail, don't despair, right? Learn more on how to save the teeth rather than just remove them. If you do have to remove teeth, if you do have to use a local anesthetic, ensure that you are aware of the maximum recommended local anesthetic dose. This is crucial. This is extremely important when you're dealing with pediatric patients. You can still take a chance with some local anesthetics in adults, but you cannot take a chance in kids. They are more prone to local anesthetic toxicity. You need to know exactly how many syringes of local anesthetic you have to give. Beyond that, you cannot give to a pediatric patient. Okay, we are used to telling our department sisters that I have an extraction schedule now, give me LA. Sisters will indiscriminately give you LA syringes, as many as you want, and if you overdose the patient with local anesthetic, complications will happen. Okay, so you need to learn how to calculate the maximum dosage for your patient based on the patient's weight. Okay, beyond the local anesthetic, for any pharmaceutical you're giving to a patient, be it any antibiotic or any painkiller, any analgesic, you need to know the correct dosage. There are certain formulae which you have to keep in mind based on the patient's weight. I personally like using the Clark's rule, and that is something which is expected from each and every clinician who is going to treat a pediatric patient. You have to also be considerate of the aberrant anatomy of the patient when you're doing any surgical procedure. Children have a different nerve innervation than adults. There is a reason why your local anesthetic will not be working as well for a kid compared to that of an adult. We'll come to that. You have to also keep in mind the rapid spread of space infections. If your patient's parents say it's all right, we don't want a root canal treatment right now, it's a milk tooth, it's going to fall off on its own, and if you are noticing a deep infection, it is your moral responsibility to warn them that this infection may increase. There may be pus formation around the tooth, and there's a very good chance the pus will spread, and if that leads to a large swelling, you need to take your kid to a hospital. Not even a dentist clinic, they need to go to a hospital. Okay, it's a dental and medical emergency. If all your procedures are done, you need to keep in mind post-surgical complications. One of them, or the most common, is oral mutilation, lip biting. If the local anesthetic has progressed for a long period of time, if the patient is not aware of any sensation on his or her lips, they can bite on them, and that will lead to a large ulcer. This is my personal experience. When I was a third year undergraduate, I had performed a surgical procedure on a child, and the procedure went fine, but the patient's parents, they came the very next day, right, in groups of 2 to 3, and started yelling at the entire department that the procedure has caused damage to my child's lip. And there was a huge ulcer on the patient's lip, and that's when the department head told them that this is not because of the clinician's fault, this is lip biting. Right? This is a normal complication which we encounter, but in fact this was my fault because I did not tell the patient that lip biting can happen. Right? So out of clinical experience, this is something which I will encourage you guys to do as well. Always inform your patient and the patient's parents that this effect may persist. Okay. Primary teeth lie very close to permanent teeth. If you are seeing any traumatic procedure, kids, they learn to walk, right? Kids will play outside, they will play outdoors, they will play indoors, they are going to bump their heads, they're going to fall off their bikes, and usually the first things which come in contact with the ground is the patient's head and the patient's teeth. If the patient has malalignment, crowding, or a class 2 profile with the proclined maxillary incisors in the first place, the teeth are going to hit the ground first. If primary teeth hit the ground first, they may get dislodged inside the jaws, called intrusive luxation, or they may get luxated laterally. They are very close to the developing permanent teeth. Such an injury can actually cause a permanent deformation in the permanent tooth. So if you encounter a patient with irregular permanent teeth, you can always ask them whether they received any injury or any severe infection of the primary predecessors. Okay. Another consideration in oral surgery is relieving abnormal soft tissue attachments. The greatest example of abnormal soft tissue attachment is your frenum. Okay, your labial frenum and lingual frenum. If they persist, they're going to cause orthodontic problems and speech problems, and they also require surgical corrections. Now let's look at these examples one by one. You need to, when you are doing an oral surgical procedure, you need to use a local anesthetic. Okay, the most commonly used is lidocaine, also called lignocaine, and slowly we are moving towards articaine as well. Now this is taken from Stanley Malamet's book, Handbook of Local Anesthesia, and it is the values of the maximum recommended dosages are also given. We'll take a clinical example. Let's say you're using lidocaine for a surgical procedure. The percentage concentration of lidocaine is 2%, which implies that 20 milligrams of lidocaine are present in 1 ml. Okay, and that would mean 36 mg are present in a 1.8 ml cartridge. In India, we hardly use cartridges. Most of the educational institutions, they use disposable syringes, which go from 2 to 5 ml. So the calculation becomes slightly different. Stanley Malamet says, or the conventional literature says, that the maximum recommended dosage for lidocaine is 7 mg per kg. Okay, so for a child who is weighing 1 kg, for an infant weighing 1 kg, the maximum dose is 7 mg. For 2 kgs, it's 14 mg, and so on. So with that knowledge, if you have a patient who is for whom you require 2% lidocaine, and if your patient has a weight of 15 kgs, the maximum recommended dosage becomes 105 mg. You cannot give more local anesthetic than 105 mg for a 15 kg kid. Now, how to correlate that with number of syringes? 105 mg, keeping in mind that 20 mg is found in 1 ml. For you to give 105 mg, you have to give 5 ml of local anesthesia. You cannot give more than 5 ml. Okay, the calculation is the same. If 1 ml of local anesthetic contains 20 mg of lignocaine, and the patient has a maximum dosage of 105 mg, this is the limit. Okay, you just use unitary method to calculate that for a 105 mg dose, that will correlate to 5 ml of local anesthetic. This is your final limit. Beyond this, the patient will experience symptoms of local anesthetic toxicity. If we are using 2 ml syringes, that would imply we cannot use more than 2.5 syringes of LA. Okay, so every clinic usually has a weighing machine, and on top of that weighing machine, you should stick a formula right there and then. You check the patient's weight there itself, and then you calculate the maximum recommended dosage for that patient there itself. All of us have smartphones. You just open the calculator, input the patient's weight, and calculate the dose right there and then. And then you tell your sisters, give me only 1 syringe or 2 syringes of LA. That's it. If LA still doesn't work, you postpone the procedure. You do not give more LA to the patient there. Okay, send the patient home, call them on some other day, preferably after 2 to 3 days, when all the LA is out of the patient's system. These are the formulae I would recommend you guys to memorize. If you cannot memorize all of them, you should memorize at least one. Okay, the most commonly used are the Young's rule and the Clark's rule. Young's rule relies on the patient's age. Clark's rule relies on the patient's weight. I prefer using the patient's weight because a 12-year-old can be thin, a 12-year-old can be obese, and the distribution of a pharmaceutical relies more on the patient's body composition rather than the age. So weight becomes slightly more reliable compared to the age. It's a simple formula. You just input the patient's weight in pounds, divided by 150, and multiplied by the adult dose of any pharmaceutical which you need to give. Be it amoxicillin, which is 500 mg, be it metronidazole, which is 400 mg, be it paracetamol, again 500 mg. If you know the adult dose of any pharmaceutical, you can just multiply it with this coefficient based on the patient's weight, and you can come up with the dose for the child. Keep in mind, this is a one-time dose. You are calculating a one-time dose. If you're using amoxicillin, this dose has to be given 3 times a day. If you're using this one, ibuprofen, you have to give it only 2 times a day, not more than that. Now, what role anatomy plays in a pediatric patient, the pediatric patient generally has smaller anatomical structures. Okay, smaller jaws, very closely placed nerves and blood vessels. Okay, so if you're using a standard LA syringe with a long needle, there's a good chance you're going to go beyond your working area. This becomes extremely critical when you're using PSA blocks. This is seen in adults as well. The pterygoid plexus of veins is very close to the upper molars, and if you go beyond that area, you're going to induce hematoma formation. If you do not aspirate your needle, if you forget to aspirate the needle while you're giving local anesthetic injections, you're going to inject all of that material directly into the patient's blood supply, and that again becomes an emergency. So to avoid all that, just reduce the depth of penetration of the injection needle, or just simply use a smaller needle to be safe. Still, even if you follow all the procedures correctly, there is a very good chance your LA will not work, or it will work not 100%. There will be some inefficiency involved. In primary teeth, they do not possess the same degree of myelination. Okay, the nerve supplies, or especially the nerve fibers which exist within the pulp of primary teeth, they have lesser myelination, and we know that local anesthetic, they act on the receptors on the myelin sheath. If the nerve cells are not myelinated to a degree, they are going to react to the LA very, very slowly, or they are not going to react at all. Okay, this is also found in chronic inflammation, where nerve cells, they lose their myelin sheath. They become less and less respondent to local anesthetics. And finally, even if you have given an inferior alveolar nerve block, there's a good chance it may not work because of the accessory innervations which come from the nerve to mylohyoid. So for you to overcome that, you have to first give your inferior alveolar nerve block and then give a supplemental injection at the floor of the mouth, so that these fibers can get anesthetized as well. It's a big task when it comes to dealing with primary molars. A lot of the time your anesthesia will not work, and then the patient cries, and then you get even more scared. Why is my LA not working? The patient is becoming uncooperative. Okay, small things will make a big difference later. Now, when it comes to dealing with the frenum in pediatric patients, you need to deal with them as early as possible before they cause long-lasting orthodontic problems. There are three ways in which you can deal with the labial and lingual frenum. One of them is called a frenotomy, where you just relieve only the anterior most area of the frenum. You just do a surgical incision and relieve only a very small portion of the area to increase the mobility of the tongue. Okay, the tongue needs to come in contact with the hard palate. Over time, let's say we go towards infancy, the tongue is required to latch onto the breast for breastfeeding. For that, the tongue requires mobility. When the patient gradually moves towards adult swallow and moves away from infantile swallow, the tongue needs to come in contact with the palate, right behind the upper incisors. And for that to happen, frenum should not be a barrier. So you're going to consider doing a small surgical procedure on the pediatric patient and relieve this frenum attachment. The complication for this, if you relieve the attachment a little too far, the tongue is going to become completely loose. And in small children, the tongue may actually collapse. They will go back, the tongue will go back and close the airway, right? And the airway will get closed, the child will choke in the sleep, and the child will die. In small children, we call it sudden infant death syndrome. Happens a lot of the times when you are doing complete removal of the frenum. In slightly older kids, frenum can be removed to a greater extent. If you are removing the frenum slightly away, maybe partial removal of frenum, not complete but not too little either, the midway between frenotomy and complete frenectomy, it's called frenuloplasty. Okay, you are retaining the frenum to a certain extent. You're relieving it anteriorly, but you're not removing it entirely. If you do remove it entirely, it is called frenectomy. Okay, frenectomy is completely harmless for labial frenum, but for lingual frenum, you need to be a little careful, because again, there is a risk of the tongue collapsing in the airway. We have discussed this already. If the primary teeth, they are in general in close contact with the permanent teeth. If the primary teeth get damaged, they're going to impact the permanent teeth, and the permanent teeth might actually erupt in a deformed fashion. Now, this is an extremely common scenario which you're going to see in almost every pediatric patient who has a long-standing cariogenic infection. Caries will spread from the enamel, dentine, and pulp and beyond the periapex. You're going to have intraoral swellings and you're going to have extraoral swellings. Extraoral swellings are more serious. If you see a patient with extraoral swellings, almost immediately consider sending them to emergency, okay, or the oral surgery department, and consider doing an incision and drainage, okay. That is called surgical decompression. If you want to be conservative, simply extract the tooth and drain all the pus out from the socket. If the patient insists on not getting admitted, if the parents say no, you do something now itself, at least open the tooth completely. Do not close it, leave it open. Just put a cotton, compress the swelling, let it drain as much as possible, and then prescribe antibiotics to a patient. This is both a dental and medical emergency. Intraoral swellings, even though they are considered emergencies, they are relatively less harmless compared to extraoral swellings. This can go on for a long period of time, for months altogether, but still you need to treat them promptly, because you never know when the infection spreads from an intraoral space, from this tissue space to a submandibular tissue space. The pathway of spread is different. Why some patients have intraoral swellings, why some patients have extraoral swellings. If the spread is medial to the buccinator muscle, okay, this is a cross section. Imagine the infection is spreading beyond the apex and it is going medial to the buccinator muscle. This kind of situation results in an intraoral swelling. Medial to buccinator, intraoral swelling. If this goes lateral to the buccinator, suppose the pus found its way outside the buccinator, it's going to go into the extraoral tissue spaces, okay, and this will lead to extraoral swelling, later cellulitis, and later Ludwig's angina, and the patient, if left untreated, the patient will die, okay. The infection can also spread through the infraorbital space or the maxillary sinus or the infratemporal fossa via valvulus ophthalmic veins, okay. So that kind of a space infection will be seen very close to the eye. We will consider it cellulitis straight away, and this is how it may look clinically. Treatment remains the same. If you admit the patient, do a surgical decompression, and then consider doing either a root canal or extract the tooth there and then, okay. If the patient does not want to be admitted, at least do an access opening and prescribe them antibiotics, IV antibiotics preferably, compared to oral antibiotics. The number one complication for local anesthesia, oral mutilation. If it's a child, if the child feels that the lips are numb, the child will bite the lip, okay. This is by default your assumption. If you have done a surgical procedure using local anesthetic, before the patient goes home, you need to warn the parent your child will bite the lip. Warn them so that they keep in mind, they discourage the child from biting the lip. And if the patient does develop lip biting, the parents are not going to come to your clinic to try to beat you up. They're going to tell you that yes, you were right, my child did bite the lip. Now what to do? It's a simple ulcer. You just debride it and let it heal on its own. You do not need to do anything else. But let's try to prevent all these pathologies from occurring in the first place. Say you have a patient who is free of any oral pathologies and you want to preserve that. You want to stabilize the patient's oral condition, or you have removed all the pathologies and now you want to ensure that these results remain stable, that new infection doesn't occur or the infection does not spread further. This is where we enter the world of preventive dentistry, okay. You are preventing not only pathologies, you are preventing trauma as well. For any of you who have been involved in contact sports, there is an importance of mouth guards. For adolescents who are learning boxing, or in the American society they have rugby, right? A lot of them, they wear mouth guards, protective mouth guards. Anyone who's learning self-defense, they're also encouraged to wear a mouth guard. Once you do that, any facial trauma does not get transferred to the teeth, and the chances of traumatic dental injuries reduce. You have to learn how to identify risk factors for any pathology. Okay, if you're concerned mainly with caries, you need to target the patient's diet, the patient's oral hygiene measures, okay, the patient's saliva, and all the factors which predispose the child to acquiring new odontogenic infections. If you see irregular anatomy, you have to make it regular. Any rough areas of the teeth, they have to be smoothened. Okay, if there is improper plaque control, you need to teach the patient brushing. If there is improper plaque control because of irregular tooth structure, again you need to target it appropriately. Also, you need to learn how to limit the spread of infection. If there is an infection and you want to prevent that infection from spreading further, you can actually arrest it. How? We'll come to it. You have to consider exploring the world of preventive orthodontics. You need to preserve spaces as much as possible. If there are primary spaces already existing in the arch, it is fine. But if there is an early loss of primary tooth, say you had your patient had a primary tooth which you just could not save, and the tooth was lost, you need to preserve that space using a space maintainer. Okay, otherwise the teeth will shift. We have early mesial shift of the permanent first molars, we have the late mesial shift of the permanent because of the permanent second molars. All of them are they're going to try to close the spaces. You need to make sure that does not happen, otherwise that will lead to impaction of permanent teeth and the patient will require orthodontic treatment later. Enamel remineralization using this GC Tooth Mousse Plus, or mainly Recaldent. Okay, you can actually push the calcium and phosphate ions back towards the tooth only if the enamel has not cavitated. Keep in mind, if there is no cavitation, if you are seeing rough enamel, chalky enamel, white spot lesion, you can reverse them. A lot of these ions already exist in our saliva. If you're going to use something like fluoride is going to encourage those calcium and phosphate ions to go inside the tooth. If your saliva is deficient in calcium and phosphate ions, say you have a patient who is a chronic drinker of soft drinks, there's a chronic loss of mineral from the tooth and there is very little mineral left, you need to supplement that mineral back inside the tooth using Recaldent. Okay, it's a wonderful material. It's like a cream. It is milk based, so you cannot give it to lactose intolerant kids, but for the kids who are not lactose intolerant, they can definitely benefit from this Recaldent GC Tooth Mousse Plus. This is something which was introduced way back in the 70s and 80s, but it got discontinued because of the potential staining on the teeth. Silver diamine fluoride. It is an amine fluoride. Okay, when we look at topical fluorides, we look at sodium fluoride varnishes or APF gels, but there's also a category of amine fluorides, extremely concentrated, okay, extremely effective against bacteria. Not only do they push the calcium and phosphate back inside the tooth, they actually kill the bacteria by acting against the enolase enzyme, and the added silver ions, they further increase the bactericidal property of fluoride. Silver diamine fluoride is what I call the Ganga Jal for the teeth. Okay, one drop of the material onto the tooth, the entire lesion becomes arrested. All the bacteria within this lesion will die. The only drawback, the silver ions will cause a black staining. Okay, just this disadvantage exists with silver diamine fluoride, but if you are going to put a crown on this tooth structure, the discoloration does not matter, which is why it is again coming back into mainstream dentistry, pediatric dentistry, and a lot of clinicians are now starting to use it again. This was extremely beneficial for us during the lockdown period, where we could not use aerosols and we could not do conventional dentistry, so we had to simply rely on SDF into arresting all the carious lesion and postponing the treatment to some other date. Now, when all that is said and done, what is expected of you? If you are receiving your training in pediatric dentistry, if you are a general dentist, if you are a pediatric dentist, what is expected of you when it comes to dealing with a pediatric patient. Okay, at least once in your life you are going to see a pediatric patient. There is no escaping that. It's not just your outpatients, it'll be your relatives' kids, it'll be your colleagues' kids. You're going to see a pediatric patient at least once in your life. Okay, might as well start training yourself for the same. What should be your knowledge base? You should be well aware of the timing and sequence of tooth eruption. Okay, this is helpful in identifying vitamin disorders. If you notice that the patient's teeth are not erupting as per the patient's actual age, something is wrong. What is wrong? The patient's vitamin D levels. Okay, if the patient vitamin D levels are suspected to be low, you need to investigate that further. Supplement those vitamin D to the patient, and the teeth will erupt on their own. You need not do any surgical intervention. In case the vitamin D levels are normal and still the tooth refuses to erupt, then you consider surgical intervention. Tooth identification. Any undergraduate, you cannot pass your exams without learning tooth identification. It is a disgrace if you pass your exams without knowing tooth identification. Okay, you need to be well aware of how a primary tooth looks different from a permanent tooth. Okay, if you decide to specialize further into forensic odontology, if you see skulls of dead kids, you need to identify primary teeth from permanent teeth to give an age estimate of the dead person. Okay, it is something which has to be kept in mind, which you need to do whenever you're practicing a specialty like forensic odontology. At the same time, you need to know whether your patient has received adequate vaccination. Say you're called for a government program and you're doing a large scale camp, and if it's in tandem with someone from pediatrics department, you need to learn how to how to arrive at the conclusion whether the patient is adequately vaccinated or not. Okay, patients who are not vaccinated age appropriately will be more prone to diseases, and that is going to add to your patient's medical history. So keep in mind, ask the patient's parents and refer the patients appropriately to their pediatrician to receive their complete vaccinations. Anticipatory guidance is something which has to be dealt with in a conversation between you and the patient's parent. You're going to guide the patient's parents in what to expect when they're dealing with the child's oral health. This starts as early as pregnancy. When you see your patient who's pregnant, you can guide them that when your child is still gestating, you have to take care of your own oral health, because the primary bacteria are transferred directly from the mother to the child. If there is a lower level of bacteria in the patient's mother, there will be low level of chorionic bacteria in the patient's oral cavity. Okay, so this is like preventive dentistry as back as it can go, as early as possible. Okay, once the child is born, how to take care of the gum pads, if the teeth start erupting, what to expect during teething. If the primary dentition is established, what are the landmarks, age landmarks by which by this age which teeth will erupt. That also has to be explained to the patient's parent. What age will the milk teeth start shedding? That also has to be told to the patient's parents. Once the permanent teeth are erupted, how to take care of them, how to do space management, whether your child requires soft tissue surgery, whether your child requires braces, all of that comes under anticipatory guidance. Okay, learn that. Learn what is normal, explain that to the patient, and only then you catch the abnormal, you catch the pathologies, and you can come up with your different diagnosis. You need to learn how to recognize signs of abnormal function or parafunction. You need to start advocating the importance of primary dentition. You need to know methods of reducing disease morbidity. You need to learn how to do disease prevention. Preventive dentistry has to be mastered. Okay, and most importantly, which is something which is easily overlooked, you need to learn interdisciplinary collaboration. Okay, if you are a pediatric dentist, you cannot run a practice without working with an orthodontist. Your orthodontist is a crucial member of your team. You need to set your egos aside and start working together. The pediatric dentist needs to work with a physiotherapist for myotherapy, for recognizing signs of parafunction and learning how to correct them. The pediatric dentist needs to work with the physiotherapist. The pediatric dentist also needs to work with the pediatrician, okay, for general reasons. Goes without saying. So whenever you are deciding to set up a practice, if you're working in a hospital, well and good, you're already in touch with these individuals. But if you're starting a practice, be it a general practice or be it a specialty based practice, if you're doing pediatric dentistry, you need to ensure that you have enough contacts to refer your patient to the respective individuals. You also need to learn caries risk assessment. It goes without saying, for every lecture that I have conducted, I have emphasized the importance of caries risk assessment. You cannot do caries management without doing caries risk assessment. Your treatment will not be stable. Caries management will not be stable until and unless you eliminate all the risk factors. And you cannot eliminate all the risk factors without knowing the risk factors, right? So caries risk assessment is one chapter you should not ignore. It will be asked for your exams and it is important clinically. You cannot run a practice, any practice, without knowing the risk factors for caries. What else is expected of you? You need to train yourself to see beyond the work zone. Okay, we already discussed the posture changes that can happen, okay, and any soft tissue anomalies and any parafunction. Okay, you also need to change your approach. The biggest mistakes undergraduates do is when the patient opens the mouth, they only see individual teeth, one tooth at a time. Whether this is a premolar, whether this tooth is a molar, whether this tooth has a carious lesion, and it stops there. We understand you are time bound. We understand that this is something which you struggle with, but you need to change your approach. You cannot focus on one tooth at a time. You need to target the entire arch. The first question you need to ask yourself whether this dentition is a primary dentition or a mixed dentition or a permanent dentition. Then you need to see whether this dentition is symmetrical, whether the midlines are coinciding, whether equal teeth are present on the left side and the right side. Only then can you differentiate the primary and permanent teeth. These things actually help you differentiate primary and permanent teeth. They help you differentiate between a spaced dentition, non-spaced dentition. They help you identify space anomalies. Okay, you need to learn how to correlate the patient's dental age with the chronological age. A child who is 10 years of age should not have primary incisors, right? If you're seeing a 10-year-old with primary incisors, something is wrong. Something is wrong and something has to be investigated. Radiographs have to be taken. CBCTs may have to be taken. Okay? History has to be kept in mind, whether the patient received any trauma, whether the permanent teeth are impacted. Okay? These things will help you determine your entire treatment plan. And finally, jaw development. Whether the mandible and maxilla have developed accordingly. Are they big enough to accommodate the primary and permanent teeth? If not, you should intervene. There are methods of expanding jaws. There are methods of promoting adequate jaw growth. If you do that at the right age, the patient may not require extensive space management, extensive tooth alignment. Okay, if you can avoid damage from happening in the first place, you should do it. Okay. So that is something you will learn only if you see the entire arch as a whole. And I'm not talking just about the hard tissues, even soft tissues. Soft tissues, they go ignored if you don't pay attention to them. Most of the times, even the postgraduates, they fail to see intraoral swellings simply because the focus lies too much on the carious lesion on the tooth. Okay, so give soft tissue that respect. You need to, and you can actually catch certain things which you may not be able to attribute directly to any pathology. Okay, if you're focusing only on odontogenic infections and gingival infections, you are limiting yourself. Certain lesions are completely asymptomatic. Certain cysts, they do not have any symptoms, they're just there. Certain changes in the color of the gingiva, they can also change your diagnosis entirely. So do not ignore anything. Your specialty lies in the oral cavity. Every inch, every centimeter has to be observed. Okay, so that is something which is expected of you. Advocate the importance of primary teeth and space management. And early loss of primary tooth can wreak havoc on the dentition. Okay, you can save the child a lot of morbidity. So please tell the patient's parents, convince them, okay, do not force me to extract a healthy milk tooth. Let it fall off on its own, and I'm going to try to preserve this tooth for as long as possible till it sheds on its own. Okay, that is your job. That is your single job when it comes to being an advocate for pediatric dentistry. Otherwise, if you let go of these signs, if you ignore them, if you don't act on them, even a well-aligned primary dentition may become crooked in the later stages of life. Okay, I tell you this by example. This patient is not my patient. This is me. When I was a kid, very nice primary teeth, but when I was an adult, the entire dentition became crowded. Okay. Now, what else is expected of you? Documentation. Please, for God's sake, start documenting your work. Okay. If you have a mobile phone, start practicing with that. Start practicing the angles on how to capture the front profile of a patient, the extraoral pictures, intraoral pictures. All the angles have to be learned. If you have not documented your work, you have not done your work. There is no proof. All right. Once you practice enough with a mobile phone, please buy a DSLR camera. Okay. Buy the cheapest DSLR camera. Okay. It doesn't cost much, cost less than an iPhone. It'll be probably 34K. Buy the DSLR camera. You can use that standard kit lens, but it is not advised. It's going to give you distorted results. Buy a 100mm macro lens. Okay, Canon and Nikon, they are the cameras which are recommended for dental photography. You can buy a 100mm macro lens to supplement your camera, and you're going to get the standard grade photographs of your patients. It is excellent. It's an excellent practice to document your work. You're going to compare before and after results. You're going to use those pictures for patient education. You're going to use those pictures to showcase your work. You're going to use those pictures to publish your work. Okay, and God forbid, if at all you are involved in a lawsuit, your patient's pictures, that's what's going to save you, because you can tell the judge, this is what I saw, so this is what I planned. Okay, this is your ultimate defense. Please document your work. Beyond photographic documentation, start taking photographs of all the x-rays that you see. Okay, the complete documentation should include a soft copy of the patient's IOPAs and bite wings and OPGs and CBCTs. There should always be one folder in your desktop, in your drive, in your cloud storage for one patient. Every patient needs to have one folder, and that folder needs to include pre-operative records, which includes photos as well as radiographs. Right? Once that is done, your treatment plan should be signed and agreed to by the patient through the informed consent. And that informed consent also has to be scanned. You need to keep a digital copy of that informed consent with the patient's signature with you. Anyone can rip a paper out of the patient's file, and that informed consent can be lost forever. But if you have a soft copy of that, you have proof. Okay, you can tell the patients, you can directly, you have agreed for this procedure, you have signed on this, I have proof of this, right? So let us go ahead with the treatment as planned. It saves you a lot of headache. Trust me. Start documenting. You need to learn how to collaborate. Okay, learn to work with your colleagues, including both dental and non-dental healthcare professionals. Okay, start working with technicians, start working with physiotherapists, start working with people from your own specialty, seniors, juniors, and people from other specialties, seniors, juniors. Work together. Okay, it goes without saying, dentists, they struggle so much because they say they have competition. The only way out of competition is collaboration. Okay, learn to work together and form those bonds, and only then you have a better practice, because you become more and more comprehensive. And finally, patience. This is the one thing which is expected from all of you. With kids, it is very easy to lose your temper. It is very easy to panic. It is very easy to get stressed. Every postgraduate undergoes burnout once a week. But you need to be patient. Okay, only then you have some success with kids. Okay, it pays off. Believe me, it pays off. Okay, learn that. Be open to suggestions. Be open to criticism. Stop arguing with patients. Stop arguing with the parents. Stop arguing with your staff. Okay, be patient, listen to what is being told to you, and then only you can observe certain things which you can easily overlook when you start arguing. Okay, be patient, it pays off, trust me. Now, with that, I will come to the end of this lecture. I just have some bonus tips for anyone who is looking towards working on a thesis, on how to come up with a thesis topic. You are just keep in mind you're dealing with a time-bound research. Okay, post-graduation lasts only for 3 years, and out of those 3 years, you can only work on your thesis for 2 years. The first 2 years. When you reach your third year, you have to actually submit your thesis way before the end of your third year. So count that out. Okay, you are doing a strictly time-bound research. So you can't deal with extensive projects. It's all right to do good research. It's very tempting to do good quality research, but time is a big factor. Okay, good quality research takes years, takes decades. You can't do that in your post-graduation. You're dealing with a time-bound research. So you have certain decisions which you need to keep in mind. The first decision, I'll just go through one by one. The first decision, you need to ask yourself whether you're doing a lab-based study or a patient-based study. Okay, lab-based studies can be in vitro or ex vivo or animal studies. In vitro studies are just lab-based studies. You acquire a material and then you test its properties. Ex vivo implies outside the mouth. So you have to, if you want to study saliva, just collect the patient's saliva and then take it to a lab. Same if you want to do blood related investigation. Take the patient's blood sample, go to the lab. Or you take the patient's GCF sample, gingival cervicular fluid sample, go to the lab. Lab-based study but using the patient's biological samples. That's an ex vivo study. Animal studies, you can take any material and then see if you can test it on an animal just to see a biological response. I personally will never advocate animal study. I understand their value, I understand the importance, but it is something which I will not encourage you to do, at least at your level. Okay. At the same time, it carries very little merit when it comes to publication. So just keep in mind, only big pharma trials which are extremely critical in developing a pharmaceutical for a patient or a large population, they require animal studies. You stay away from animal studies as much as possible. So these studies, lab-based study, they save time. Okay, this can be as short as 1 month. My personal thesis had to be cancelled because of COVID-19. So I changed my thesis 1 month before the submission date and I finished it in that time. It is possible. Okay, but it is extremely technique sensitive. Okay, if you're dealing with materials, dental materials, it's a pain to nail every parameter right. You have to mix them properly, you have to proportion them up accordingly. The exact weight, exact technique matters a lot. Okay, a lot of things can go wrong. If there are 100 steps to a procedure, even if one step goes wrong, the whole thing goes wrong. So that is one major drawback of in vitro studies. Okay, extremely technique sensitive. A lot of times you will find yourself outside your area of competence. Okay, lab procedures are not taught to us in our curriculum, so you have to rely on technicians, you have to rely on researchers to help you out. Okay, that there is always a need for external aid. And both in vitro studies and animal studies, they have low research value. There is a pyramid, a hierarchy of research where the reviews, systematic reviews and clinical trials are kept at a higher position compared to in vitro and animal studies. Maybe within yourself you might feel, I did not do a meritorious research, I did not do a great study, but at your level, with the time frame you've been allotted, in vitro studies is a very, very good option. Still, if you do want to do a patient-based research, that is called an in vivo study inside the patient's mouth, you can go ahead with it, but it is time consuming. Okay, because almost every patient-based study requires a follow-up, 6-month follow-up, 1 year, 2 year follow-up. It requires a lot of patient compliance. If you have given them something new, a new material, there is no way of telling whether the patient has actually followed your instructions. Okay, you just have to trust them. You have to trust them to follow your instructions. You have to trust them to actually show up for the appointment, for the follow-up visits. And a lot of time that does not happen for some reason or the other. That is called patient attrition. They do not turn up for the follow-up. But in vitro studies, patient-based studies, they are least technique sensitive. Okay, I'm not saying that there is no technique involved whatsoever, but comparing a lab-based study, it is less technique sensitive. Okay, you can do your standard procedure, you can do your regular work, and you can include that patient for your research, and you are all set. As long as you have a follow-up, all you need is a picture, and that's it. Okay, and at the same time, these trials have a high research value. Okay, if you can take that risk, please go ahead. In vivo studies also a very good option. So this is your first decision which you need to keep in mind, whether in vitro study or in vivo study. Once you've decided, then you need to come up with a topic. Exactly what topic you have to research on. Coming up with a thesis topic, you are expected to do new research. So that would mean going online or going to product manufacturers and figuring out if there is a new material out there in the market. Okay, you know your manufacturers, you know 3M, Dentsply, Pulp Dent, Voco, right? These companies, you know them already. So start going through their catalogs, start going through their websites. Okay, look for new materials. Otherwise, you can look into published literature as well. See if any research has been done already. Say you found a new material and you found one study which has investigated the compressive strength of that material, but that's it. So you can do a research on the tensile strength of that material, or flexibility, or wear property, color stability of that material. Okay, as long as there are parameters, you can do new studies. The second method is what I call scuttlebutt. Okay, scuttlebutt is a fancy word for gossip. Okay, so you need to, this is basically you asking your colleagues, okay, is there something new out there? You can ask your seniors, you can ask people from other colleges, other institutions, your colleagues, your faculty. If there are any ongoing studies in the department, you can contribute to that. You can take their results and extrapolate them to your study. With that approach, you can come to at least something new. And then you have to be creative. You have to start making combinations, new material, new technique, parameters, and you can start matching. Even if you're investigating 2 parameters for this new material, it's fine. You have a thesis in hand. Once your topic is decided, once you have figured out which material you want to study, which technique you want to study, and whether you want to do lab-based study or patient-based study, you need to consider collaboration. Again, collaborate. Okay, you will be getting expertise from various fields. Okay, some of you will be working with biochemistry departments, some of you will be working with engineering departments. Okay, it's a great learning experience. You are going to learn from them, right? And if you're doing dental collaboration, you're going to work with your sister departments. A pediatric and orthodontic based study is possible, and endodontic and periodontics based study is possible. Okay, oral medicine and oral surgery, if you're investigating some sort of tumors or cysts, it is possible. You're going to work with oral pathology as well. Okay, the more collaborators are there in your study, the better it is, because once you finally start to publish your results, when it comes to financing, right, say you want to put your study in a paid journal, if you have more collaborators, the cost gets divided equally. So the greater the number of collaborators, the greater the number of people scrutinizing your study, the value of your study increases. Okay, and say you found an international author, right? You got in touch with a company and they referred you to their expert from some foreign university. They will offer you an international standard perspective. I'm not saying their perspective will be better than yours, but I'm saying it's still a different perspective. Okay, they will tell you the situation in their country, how the material is being sold in their country, how the material is performing in their country, and how you extrapolate those results to your country. Okay, international collaborations are important. Again, do not glorify international collaborators. They are not gods. Okay, but they offer you a different perspective. Okay, and that becomes important. Once you have decided on the type of your study, the topic of your study, whether you need collaboration or not, you need to ask yourself, how are you going to finance your study? Research is not cheap. Every test requires money. Okay, and for that you need to know your budget. Okay, you need to fix your budget. As a postgraduate, no one is expecting you to shell out lakhs of rupees Okay, it's simply impractical to do that in your post graduation. uh, a rough benchmark you can say is 20,000 rupees. You will be spending minimum 20,000 rupees for your thesis research. So look into college grants. I know some colleges they give 10,000 rupees student grant, and that is not enough. So you have to do personal financing as well. But ICMR provides a 50,000 grant. Every postgraduate should apply for ICMR grants. Okay, even undergraduates can apply for ICMR grants. They go up to 50,000, even up to 1 lakh. If you do get an ICMR grant, it is considered a big deal. So please apply for it. You can also look into corporate grants. Certain companies they put out corporate proposals, and how to access those corporate proposals, you have to ask your faculty, your guides, thesis guides. They're going to teach you how to access those, because every institution has a portal, and only the faculty are allowed to access that portal, so they receive all the grant calls. There are certain free platforms as well, like Pure Elsevier, and then you can just see a list of all the grants which are out there. The problem with corporate grants is that the money gets locked in. Once you receive that money, the money goes straight away to your institution, not your account. And the institution, you're basically at their mercy, that you have to write them tens and hundreds of emails just to release some money. So you win some, you lose some. You can also look into company sponsored materials. This is something which I did. I got in touch with the company directly, and I researched this material. 1 second. This Activa Bioactive. This is my. I had researched this material's mechanical and chemical properties. I got in touch with Pulp Tent, and they had sent me multiple samples. So I saved up on hundreds of dollars already. So that is also an option. All you need to do is write them an email. You can send reminder emails as well. A lot of times they do answer. It becomes a great learning opportunity for you guys. If nothing works, use your personal savings. If you have come this far, might as well, right? You have to finish this anyway. Shell out some of your own money. And if that also is not enough, look into collaborators. More people involved in your study, the financing becomes a little easier. Finally, outsourcing. If your institution lacks the utilities, the infrastructure to carry out your research, you can actually get in touch with other colleges. Okay, say they have their engineering department, they have their biomedical department. You can courier them your samples. They will charge you a fees, and then they will conduct the investigation and send you the results. It's a very convenient option. If you know the right people, if you know the right departments, your work can get outsourced. And there's a small chance they will ask for authorship, but that's all right. It's not that big of a deal. The more the merrier. The second bonus tip, this is applicable for everyone. My students know how I feel about Indian authors and their textbooks. So I am not a big fan of Indian authors. I will always advocate the Bibles of Pediatric Dentistry. For every topic, be it an exam going topic or non-exam going topic, for your research, for your casual reading, if you find yourself with a question, you're going to find its answer in these books. Okay, dentistry, for these three are the comprehensive pediatric dentistry textbooks. McDonald and Avery's Dentistry for the Child and Adolescent. Pick any edition. Most of the time you will find it in your college library. Infancy through Adolescence, Pediatric Dentistry. And then Matthewson's Fundamentals of Pediatric Dentistry, 3rd edition. This is the only edition which has come out recently. After that, they have not released anything. This came out in 1997, but a great book for clinical pediatric dentistry. If you want to read about traumatic injuries, wound healing, mechanism of defense by the body, this book. One of the most beautiful books I've ever read. Extremely well illustrated. You're not going to get bored reading this. You may find yourself struggling a little bit with this book, especially. The language is a little research oriented. So for an undergraduate, this book might be a little difficult. I will say you stick with this, and this. Okay. And finally, the ultimate database, the ultimate place to refer anything related to pediatric dentistry. It's the greatest compilation of all the systematic reviews which you can find. They are given as guidelines by the American Academy of Pediatric Dentistry. Everything is given. Instructions step by step with current recent evidence. Okay, in your answer, if you want to cite the authors and you cannot think of any authors or think of any studies, cite the AAPD guidelines. No one will ever question you. Okay, this is your ultimate crash course in pediatric dentistry. For towards the end of your university exams, this is what you should refer. Okay, you will be in touch with the latest trends. This is knowledge beyond the textbooks. I'm not saying you should refer only this. Read this and then move on to this, and only then you move on to individual studies. Okay, this is something which you should not skip. Okay, keep in mind. This is the vaccination schedule given by the National Immunization, the Ministry of Health and Family Welfare. Find it online, take a printout, keep it in your study area or keep it in your clinic. Okay, for you to learn, for you to slowly start memorizing the vaccination schedule, because you are a doctor first and then you are a dentist. And if someone asks you that as a pediatric dentist, are you well aware of the vaccinations which a child goes through, your answer should be yes. Okay, this is given by this schedule is given by the Indian Academy of Pediatrics. They're all pretty much the same. You can pick any of them, take a printout and start memorizing them. If you get a really cruel examiner in your final university exam, they may ask you vaccination schedule as well. It's all right, they're not expecting you to know this, but if you do know this, there are free brownie points to be given. These are the links where you may find these resources, but just keep in mind AAPD and Ministry of Health and Welfare. You're going to find these two tools. And with that, we come to the end of the lecture. It's a lot to take in when you look at pediatric dentistry in its entirety. It's a rabbit hole. It does not stop. It goes the same for every specialty. The more you read, the more there is to read. And the more you think you know, the more you don't know. So my job was to just give you a brief orientation to the things which are there in pediatric dentistry. Over time, we are going to deal with more detailed lectures over each of them. Again, the feedback is open for everyone. If you have any particular topics in mind, do let me know. But keep in mind, I don't want to teach you for your exams, right? I just want to change your mindset so that when you actually do read your own books for your exam, you do not simply mug up, right? You're going to implement it clinically. The best way to learn all that is to implement it clinically. So that's my goal. Regardless, if there is still a demand for academic oriented lectures, I can take them, but I may charge you guys for it and I may not be able to conduct them free of cost. We'll see. If it comes to it, we'll cross that bridge. Other than that, the lecture is done. I am open to discussion and I shall see you guys next time. Take care. Bye bye.